You hear the stretcher before you see it. A patient arrives in the emergency bay. Their arm is severely swollen, tense, and darkening. Just above the swelling, a narrow rubber tourniquet cuts deeply into the flesh. Alongside them, a panicked family member holds out the severed head of the snake that bit them. The instinct in this moment is to figure out exactly what kind of snake is responsible. The clinical team crowds around, squinting at the mangled remains, or swiping through blurry cell phone photos, trying to match scale patterns to a textbook. But local snake names vary, descriptions from frightened patients are unreliable, and bites usually happen in the dark or in thick brush. While the team debates whether it's a viper or a cobra, venom is actively destroying tissue or shutting down the patient's respiratory system. Clinicians do not need to be herpetologists to save this patient. In the high-pressure environment of a rural clinic, identifying the species is often impossible. Instead, we rely on syndrolic management. We look at the physiological signs the patient's body is showing us. By following a strict 4-step clinical protocol, we replace the panic of the unknown with precise, data-driven medical care. Step 1 is your primary survey, A, B, C, D, E. First, keep the patient completely still. Movement and fear accelerate the heart rate, which speeds the lymphatic spread of the venom. If you observe any signs of neurological impairment, like drooping eyelids or shallow breathing, secure the airway immediately. Have your ventilators prepared and ready before full paralysis sets in. Next, halt harmful community interventions. Never cut the wound. Slicing fang marks introduces bacteria and risks bleeding. Never suck out venom. You cannot remove bound toxins. Do not apply herbal pastes, which cause infection. And crucially, do not use tight rubber tourniquets. Step 2 is assessing the wound and managing those constrictions safely. If the patient arrives with a tourniquet, do not remove it right away. First, secure IV access with 2 large-bore cannulas, preferably green or gray. If you release a tourniquet in a swollen limb too quickly, trapped venom and acidic, oxygen-deprived blood surge back into central circulation all at once. With your IV access confirmed, release the tourniquet very slowly. Watch the patient's blood pressure closely as those trapped toxins return to the bloodstream. Having those IV lines ready ensures you can push fluids and medications the exact moment blood pressure drops, preventing sudden cardiovascular collapse. Step 3 is syndromic identification. Snake venoms in our settings generally fall into 3 main toxic profiles. The skin, nervous system, and blood will tell you exactly which one you are dealing with. This left panel illustrates cytotoxic viper venom. It acts like a chemical fire, causing massive swelling and tissue death. As swelling increases, pressure crushes blood vessels, stopping blood flow. This causes a surgical emergency known as compartment syndrome. The middle panel shows neurotoxic cobra venom attacking the nervous system. You see fast descending paralysis, drooping eyelids, and trouble swallowing, ending with diaphragm paralysis and silent suffocation while fully conscious. The right panel represents hemotoxic boomslang venom, which consumes clotting factors. The blood loses its ability to clot, leading to systemic bleeding from gums, nose, old wounds, and internally into the organs and brain. To confirm hemotoxicity, we use a simple, vital bedside investigation, the 20-minute whole blood clotting test. Draw a few milliliters of the patient's venous blood, place it in a clean red-top glass tube, and leave it completely undisturbed at the bedside for exactly 20 minutes. After 20 minutes, gently tilt the tube. If the blood forms a solid clot, clotting is intact. If it stays liquid and flows down the glass, you have undeniable proof of hemotoxic envenomation. By treating blistering tissue, supporting the failing airway, or identifying liquid blood in a glass tube, you remove all the dangerous guesswork. The physiology tells you exactly what to treat. Step 4 is administering antivenom. Antivenom is a high-risk biological drug with a serious chance of causing anaphylaxis. It is not a painkiller, and you never give it for a dry bite where venom wasn't injected. You only prescribe it for clear systemic signs, progressive neurotoxic paralysis, systemic bleeding, or massive swelling that crosses a joint. Before you mix a single vial, draw up IM epinephrine, IV hydrocortisone, and IV chlorpheniramine. Have this emergency kit ready and waiting at the patient's bedside. Dilute the required dose, usually 2 to 5 vials of polyvalent antivenom depending on severity, into 250 to 500 milliliters of normal saline or 5% dextrose. Do not reduce this dose for children. A snake delivers the same volume and potency of venom to a child as it does to an adult, so the child needs the exact same amount of antibodies to neutralize it. On this cheat sheet, we map out drip rates. Begin the IV extremely slowly. Using a micro-drip burette set is the safest option. Run it at 120 drops per minute, which is exactly 2 drops every second. If you lack a burette and only have a standard adult set, adjust your math. Run the infusion at 40 drops per minute, which equals roughly 2 drops every 3 seconds. Stay at the bedside for the first 15 minutes. Check vitals every 5 minutes, watching closely for early signs of type 1 hypersensitivity, like shivering, hives, itching, or a sudden drop in blood pressure. If anaphylaxis occurs, you must stop the infusion immediately and rapidly push the IM epinephrine you prepared earlier. Strictly adhering to these drip rates and actively monitoring at the bedside ensures the biological neutralization process occurs with a constant safety net for allergic reactions. Once the protocol is complete, the venom's destruction halts, the patient breathes easily, and the limb is saved from amputation. This stability is achieved because you bypassed the panic of trying to name the snake. You trusted your primary survey, relied on the 20-minute clotting test for hard data, and managed drug delivery safely. Now take this protocol out of the hospital. Teach your colleagues and your communities the absolute do-nots of snakebite care. We have to stop the use of tourniquets and razor blades before the patient even reaches the clinic doors. Effective emergency snakebite care relies on a clinician who focuses on the patient's physiology, following the steps to deliver precise care when every second matters.